Assalamu alaikum wa rahmatullahi wa barakatuhu. So let's today discuss about a very important topic, especially while giving empiric antibiotic therapy to empiric therapy to a patient with fever, or giving therapy to those patients in those areas where the access to lab investigations is not there. So in those patients, this is very much helpful, and uh, helpful in those geographical areas like in the underdeveloped countries and developing countries where access to the lab investigations and radiographic investigations is not there. So let's begin with the name of Almighty. So the topic is syndromic management of fever. Syndrome is nothing but syndrome is nothing but group of diseases. Okay, so group of diseases which cause fever. So syndromic management of fever. The syndromic approach categorizes patients based on distinct clinical presentations, nothing but syndromes, rather than waiting for specific etiological diagnosis. This is important in tropical regions where diverse pathogens, example malaria, dengue, scrub typhus, and leptospirosis, malaria, dengue, scrub typhus, leptospirosis, and enteric fever often present with early similar symptoms. So, what is the core principles of this syndromic management? Early empiric therapy. Initiate treatment for life-threatening conditions. Example: severe malaria, bacterial sepsis, rickettsial diseases, based on the clinical syndromes while awaiting test results. Second is categorization. Classify patients into major clinical syndromes to narrow down the differentials. Third is risk stratification. Identify red flags, signs of severe disease or organ dysfunction immediately. So these are the core principles. So this is for early empirical therapy and categorize the patient, for example, into the clinical syndromes like fever with chest symptoms, fever with cardiovascular symptoms, fever with CNS symptoms like that, and then risk uh, to for risk stratification of the patients. So how does it work? So here is the flowchart. Systemic approach to infectious. First, you will identify clinical syndrome, like patient presents with fever and symptoms. You will take a detailed history and physical examination. Detailed history and physical examination. So duration is very important. Acute, you call it as less than 2 weeks. Chronic, you call it as more than 2 weeks. And you see the epidemiology, whether there is a history of travel, what is the occupation of the patient, what is the season, okay, because seasonal variation is there. Host factors like whether the patient is diabetic or HIV positive or on immunosuppressants or immunocompromised or chemotherapy. So all these things. So you will uh, uh, identify syndrome based upon the patient fever and symptoms, history and physical examination. In history and physical examination, duration of fever, epidemiology, meaning nothing but exposure history based on duration. Same thing which I explained in the topic of fever detail, duration, and this is exposure history, and this is nothing but localizing signs, localizing symptoms and signs. Based upon these three, so that means the patient is having some localizing symptoms and signs. So based upon that, we'll treat the patient. Okay. Then organ system classification. Localize the infection. For example, if the patient has cough with breathlessness, that it is fever with respiratory symptoms. If the patient has altered sensorium or seizure, that can be meningitis or encephalitis. That is known as fever with CNS symptoms. Patient may have dysuria, diarrhea. That is fever with genitourinary or abdominal symptoms. Undifferentiated fever is patient does not have any clinical localizing signs. Next. So based upon the syndromic diagnosis, we'll give the empiric therapy. Narrow differential based upon the syndrome. Acute undifferentiated fever, meaning the patient doesn't have any symptoms. It is acute, meaning it is less than 2 weeks. Then rule out malaria, dengue, and scrub typhus in those patients. These are the common important differential diagnosis. Malaria, dengue, and scrub typhus. Fever with rash, rule out rickettsia, measles, meningococcemia in these patients. Start empiric therapy. Example, doxycycline and ceftriaxone. Then after starting empiric therapy, before giving this empiric therapy, you will send uh, for cultures like blood and urine culture, serogenic NS1 for dengue, IgM ELISA for typhoid and dengue as well, and for scrub typhus, molecular like PCR and NAT. Then after confirmation by the lab, you will de-escalate that to a specific therapy. So this is nothing but the syndromic management of diseases. Now coming to the major clinical syndromes and their management. The following syndromes are the standard framework for evaluating acute febrile illness. So first one is acute undifferentiated fever. Definition: fever less than 2 to 3 weeks without localizing signs, no rash, no organ specific symptoms like cough or dysuria. The common etiologies are, you can classify it as viral, bacterial. In bacterial, you can classify it as typical, atypical, and parasite. Okay. So viral is, here you can think influenza, dengue. Okay. Bacterial is enteric fever, leptospirosis, scrub typhus, and parasitic is malaria. So these are the common etiologies. Okay. Now what should be the diagnostic algorithm? So in these kind of patients, so after 4 days, no, so till 4 days, if the patient is stable and patient does not have any syndromic presentation, meaning does not have any specific symptoms or signs, so till 4 days we'll manage the patient it as symptomatically according to the Merck's Manual of Medicine. Then after 4 days, you will give empiric treatment even though patient does not have any symptoms and signs, considering the common etiologies. Before giving empiric treatment, what you will do? Rule out malaria. Performed Perform rapid diagnostic test for malaria or by peripheral smear, and rule out dengue in this patient. Rule out malaria and rule out dengue. Dengue NS1 antigen if the patient is presenting 1 to 5 days, and IgM ELISA if the patient is presenting more than 5 days. Then, if the patient is malaria positive and if it is Plasmodium vivax, so give chloroquine for 3 days and primaquine 14 days for radical cure. And if it is Plasmodium falciparum, then artemisinin based combination therapy should be given. Severe cases should receive IV artesunate. Okay. Now, if the patient is negative for malaria and dengue, then give empiric treatment for typical and atypical bacteria. Like, consider empirical doxycycline 100 mg BD for 5 to 7 days to cover the rickettsial infections like scrub typhus. And for those for scrub typhus, the specific pathogenic sign is eschar. You may have thrombocytopenia, transaminitis, and consider empirical azithromycin or ceftriaxone if enteric fever is suspected. So we will have stepladder type of fever and relative bradycardia. Relative bradycardia you can also have in atypical bacterial infection, because remember one important point is intracellular bacteria cause this relative bradycardia. Okay, so this is the empiric therapy: ceftriaxone with doxycycline once you have excluded malaria and dengue. If malaria or dengue is present, then you should manage accordingly. If malaria and dengue are excluded, then you should give empirical treatment with ceftriaxone or azithromycin and doxycycline. Supportive measures are paracetamol for fever. Adequate hydration should be given to the patient. Avoid NSAIDs because there is a risk of bleeding in dengue patients. Okay, that's about the syndromic management of acute undifferentiated fever. So this is the flowchart showing the same things. So management of acute undifferentiated fever. Fever should be less than 2 weeks, and there are no localizing signs. Now you see that now you see the red flags. If the patient has red flags like hypotension, breathlessness, respiratory rate more than 24, bleeding or petechia, altered sensorium, oliguria or jaundice, so these are signs of organ failure. Persistent vomiting. Okay, if the red flags are present, then admit to ICU, give IV fluids, blood culture should be sent, and start broad spectrum antibiotics. Okay, meanwhile send the investigation for malaria, okay, dengue and scrub typhus. Now if that is positive, then treat specifically like malaria and dengue. Now if these three things are negative, okay, these three are common diagnosis uh, uh, in acute undifferentiated fever. That's why we are excluding these three things. Now if these three things are negative, okay, and if fever is still persisting for more than 48 hours, meaning 5 days have gone, okay, then repeat the assessment, check CBC, check urine routine, search for eschar, and empiric therapy should be considered. If high suspicion for rickettsial or typhoid, doxycycline, azithromycin, and ceftriaxone should be given. Now that's about red flags if the patient has. If the patient does not have red flag and the duration is less than 7 days, if you think, if the duration is less than 7 days, no red flags and the duration is less than 7 days, manage symptomatically like paracetamol, hydration. Okay, that is the symptomatic. Now if the duration is no red flags but the duration is more than 7 days, again now Here there was no typhoid because uh, serological test for this typhoid, this viral test is positive after 1 week. You can exclude even typhoid if the patient is presenting after 3 days by doing IgM ELISA for typhoid here also. But if the patient has fever more than 7 days, then consider typhoid in your differential diagnosis. Typhoid, scrub typhus, leptospirosis, okay. And if these are present, then treat for them, okay. And if these are not present, again you give empiric therapy, like that, okay. Now coming to fever with rash or fever with thrombocytopenia. So what are the common etiologies? Common etiologies again you divide into viral, bacterial. Bacterial can be typical and atypical. Then parasitic. Okay. So viral is viral exanthems you can have. In children you can have measles, adults dengue. Okay. Bacterial is meningococcemia and rickettsial infections like scrub typhus and spotted fevers. Clinical clues include eschar, pathognomonic for scrub typhus, often found in groin and axilla. Petechiae and purpura suggests dengue or meningococcemia. Remember this point. Petechiae or purpura suggest dengue or meningococcemia. Management. If dengue is the diagnosis, then fluid management is critical. Monitor the hematocrit and platelets. Platelet transfusion should be done only if the count go down to less than 10,000 or if active bleeding is noted. Rickettsial doxycycline is the drug of choice. Meningococcemia, urgent IV ceftriaxone should be given. So this is the algorithm for management of fever with rash and or thrombocytopenia. So fever with rash, characterize the rash. This is important. Characterize the rash. Whether the rash is micropapular, whether the rash is petechial or purpuric, and whether the rash is eschar type, cigarette burn type. Okay. If the rash is petechial or purpuric, then there are the diagnosis. Check the platelets and BP first. If the rash is petechial or purpuric, then check the platelets and BP. In BP, you can have this tourniquet test positive while testing the BP. Okay. Suspect dengue. Okay. Suspect meningococcemia. So dengue will have high hematocrit and low platelets. Meningococcemia will have shock. Leptospirosis will have renal failure or liver failure. Rickettsial spotted fever, usually this will present as encephalitis. Okay. So dengue, typical bacteria include meningococcemia, atypical include leptospirosis and rickettsial spotted fever. So critical care should be given, fluid resuscitation should be given. If meningitis is suspected, give IV ceftriaxone 2 grams stat. If dengue is a fluid algorithm, NS or RL, platelet transfusion should be done only if the count go down to less than 10,000 or bleeding is noted. Now, if macular papular patch, measles like rash, then check history for vaccination and joint pain. Why joint pain? Joint pain is a feature of chikungunya. Okay. Then suspect viral exanthem, measles in children, chikungunya, and chikungunya. Okay. Chikungunya and drug allergy. Give fluids and antipyretics. That means dengue presents with petechial and purpuric rash. Okay. Even it can present with maculopapular rash with centrifugal distribution. So you should also include here dengue. Okay. Dengue also should be included here. Then eschar if there is a pathogen of scrub typhus, start treatment with doxycycline or azithromycin. Okay, so that's about fever with rash and thrombocytopenia. Now fever with respiratory symptoms like fever with acute respiratory distress syndrome. Common etiologies viral include severe influenza, COVID-19, hantavirus, bacterial pneumonia, severe, scrub typhus, rickettsial, leptospirosis. Okay, key investigation include ABG, chest X-ray or CT chest, malaria test because malaria can also have involvement of chest, scrub typhus serology and blood cultures. Management include oxygen therapy, maintain SpO2 more than 90 to 92%. Okay, and if the patient is a chronic pulmonary disease patient, then saturation should be maintained between 88 to 90%. Empiric antimicrobials should be given. Okay, oseltamivir, which is an anti-influenza agent, 75 mg BD for suspected influenza in patients in adults. In children, it is I think 6 mg per kg dose. No, it depends upon the weight. Okay, the dose of oseltamivir. Then, so one you have given because respiratory manager you have given oseltamivir. Okay. Second thing you give is ceftriaxone plus azithromycin or doxycycline for atypical pneumonia, scrub typhus, or leptospirosis. Fluid management is important. Conservative fluid strategy to avoid worsening pulmonary edema. Okay. So now algorithm for fever with respiratory symptoms. Fever with respiratory symptoms. Fever with cough, sore throat, or breathlessness. Assess the anatomical site whether it is upper respiratory tract infection or lower respiratory tract infection. Upper respiratory tract infection symptoms include rhinorrhea, sore throat, and sinus tenderness. Etiology likely will be viral, rhinovirus, or influenza, or COVID-19, or group A streptococcus. Management symptomatic like steam or gargle, antihistaminics, observation. And if group A streptococcus suspected, you should give antibiotics like azithromycin. Lower respiratory tract, if fast beating is there, more than 24 per minute, chest and drawing is there, crackles or craps on auscultation, then assess the severity of LRTI based on curve 65 score. If there is any C for confusion, U for urea, R for respiratory rate, and B for BP. 65 is the age of the patient, more than or equal to 65. So if the score is 0 or 1, then it is considered as low risk. If the score is more than 2, okay, more than or equal to 2, then it is considered as high risk. So low risk patients should be managed as OPD, given empiric antibiotic therapy like azithromycin or amoxiclav. High risk patients should receive three things: ceftriaxone, azithromycin, and oseltamivir, depending upon the common etiologies. That's about fever with respiratory symptoms. Now coming with fever with CNS symptoms. Fever with encephalopathy. Common etiologies includes, here you can see malaria. Viral encephalitis include Japanese encephalitis virus, herpes simplex virus, and bacterial include bacterial meningitis and tubercular meningitis. Important point. Okay, atypical bacteria, scrub typhus and leptospirosis, and parasitic cerebral malaria. Management include stabilization of the patient, ABC, airway, breathing, circulation. Treat seizures, okay, with lorazepam, levetiracetam, and treat the raised intracranial pressure with mannitol or hypertonic saline. Okay. Empiric meningitic cocktail, meaning empiric therapy for patient presenting with meningitis or encephalitis. So give IV artesunate for malaria, IV artesunate for malaria, and then IV ceftriaxone or vancomycin plus ceftriaxone for bacteria, IV acyclovir for HSV, doxycycline for scrub typhus and rickettsia. These much of empiric therapy should be given in patients with presenting with CNS symptoms. Now this is a flow chart, important flow chart. We will see this one. So patient presentation: fever with CNS signs like altered sensorium, seizures, okay, focal deficit, GCS is less than 15, or the patient present with delirium. The first stage is immediate stabilization of the patient. Airway, breathing, secure airway, oxygen should maintain more than 92%. Circulation, IV fluid should be given. Vasopressor should be given if there is shock. Control the seizure with IV lorazepam, then levetiracetam can be given. This is important. Check the glucose in patients presenting with CNS symptoms, because hypoglycemia and one more is sodium. Hypoglycemia and hyponatremia, they produce CNS symptoms. So the checking of these two things, glucose and sodium, are very important. Treat sodium if patient has low sodium, particularly less than 125 milliequivalents per deciliter, you should treat. And glucose, treat if it is less than 70 milligram per deciliter. So now you have stabilized the patient. Now you assess for the patient presenting with these whether there is increased intracranial pressure in these patients. What are the clues for that? Papilledema in fundoscopy, bradycardia if you palpate the pulse, focal neurological deficits. For example, patient will not be able to talk properly, or there can be ophthalmoplegia, okay, or patient may have one limb sensory deficit or motor deficit of limbs. So that's another focal neurological. So these three things important: eye sign and bradycardia and focal neurological deficit. These point towards increased ICP. Then if yes, then it is considered as high risk, and give anti-edema measures like mannitol and hypotonic saline. Urgent CT brain should be done. Lumbar puncture is contraindicated if these features are there, if these signs of edema are present in the patient. Which are the signs? Those are papilledema, and second one is bradycardia and focal neurological deficit. If no these signs are not there, papilledema is not there, bradycardia is not there, focal deficit is not there, then immediate lumbar puncture should be done, and that should be sent for CSF, sent for to know the cells, protein, sugar, gram stain, and IgM panels. Syndromic therapy for these patients, the golden hour, start within 60 minutes. What is the syndromic therapy? You should cover many bacteria, you should cover virus, you should cover rickettsia, you should cover malaria. Okay. In respiratory symptom, you should cover influenza there. Okay. Then IV ceftriaxone, 2 gram IV BD should be given, or meropenem. So the dose of ceftriaxone is meningeal dose should be given in meningitis. 2 gram IV BD or meropenem can be given. For viral you should give you should consider the common cause HSV. Injection acyclovir 10 mg per kg IV 3 times should be given. Rickettsial cover, scrub typhus, endemic. Injection or tablet doxycycline 100 mg BD should be given, or you can give azithromycin. Malarial cover should be given, that is nothing but IV artesunate 2.4 mg per kg IV, that should be given. Okay. De-escalation and definitive care after 2 to 3 days when the reports are available. So if lumbar puncture, lumbar SCSF shows neutrophilic, meaning the neutrophil count is raised and the sugar is low, that means it is a bacterial cause. Continue the antibiotics for 10 to 14 days. Stop other things. If viral, there will be lymphocytes will be more and sugar will be normal. Then continue acyclovir and give supportive treatment. And if it is rickettsial, then IgM will be positive. Then continue doxycycline. Okay. And if it is TB, this is also important. We have not considered this. TB meningitis is also important, but it will not be acute to be more than 2 weeks or 3 weeks. Okay. Presentation, fever with CNS symptoms. So lymphocytic will be there, but with low sugar. So how you differentiate from viral? In virus, sugar will be normal, whereas in TB, sugar will be low. So start ATT with steroids, dexamethasone, 8 mg 3 times daily for 3 days. Immediate stop after that. Okay. So this is one more table from API textbook of medicine. CNS infections include meningitis, encephalitis, brain abscess, and empyema. Okay, meaning CNS from these things, CNS presentations. Complaints include nausea and vomiting, very important. Headache with nausea and vomiting, fever, photophobia, seizures, blurring of vision, focal deficits. If there is altered mental sensorium, think meningoencephalitis, okay, and ADEM and encephalopathy or space occupying lesions like brain tumor. Okay. No altered mental sensorium or no, these signs are not there, then you consider epidural abscess malarious, meaning something related to spinal cord. Now, what are the diagnostic workup and examination in these patients? History, physical examination, vitals you should check, meninges neck stiffness you should see, papilledema, neurological localization you should see, vertebral tenderness you should see, heart murmur you should see, abdominal tenderness you should see. Diagnostics include blood tests like CBC, KFT, LFT, procalcitonin, cell fluid analysis meaning CSF, protein, sugar, differential count, and adenosine deaminase for tuberculosis. Microbiology, blood culture, CSF cultures, aerobic and anaerobic both, erythroid lavage, CBNAT for TB, AFB liquid culture, multiplex PCR panel for meningoencephalitis, and serology. Urine routine and culture, histopathological examination, epidural or intradural abscess if you suspect. Radiology includes CT head, MRI brain, MRI spine, CT abdomen, or chest 2D echocardiography. Okay. That's about the fever with encephalopathy. Okay. So CNF, it is involved. It can be viral, bacterial, parasitic, and in bacteria, typical, atypical, and tubercular. Malaria can also be there. Okay. And ATP. Okay. Now, fever with abdominal features. Coming to fever with abdominal features. That is acute febrile abdomen. Patient presents with fever, abdominal pain, localized or diffuse, abdominal distension, vomiting or diarrhea, acute presentation. So what you should do, you should first stabilize the patient, airway breathing, circulation, pain management with IV analgesics, and nil per oral status, nil per os. Okay. Meaning Rais tube should be inserted into the patient and orally nothing should be given. Now you see whether the patient, is it a surgical emergency in the patient? So the signs pointing towards this is number 1, peritonitis. Number 2, obstruction. Peritonitis, obstruction, and perforation signs. So how do you know peritonitis? So three things are guarding, rigidity, and most specific sign is rebound tenderness. And in generalized peritonitis, what you will see, boat-like stiffened abdominal wall you will see. Okay, that is peritonitis. Obstruction, if you auscultate the patient, there will be increased bowel sounds. In obstruction. Perforation, if you obtain a chest X-ray, you can see air under the diaphragm. So that's how you notice. So basic investigations are ultrasound and chest X-ray. So if high risk is there, then refer to the surgery department. Okay. If now it is a low risk, then do the labs. That means you're first you are differentiating into whether it is a surgical emergency or not. If it is a surgical emergency, perforation, peritonitis, or obstruction, perforation, peritonitis, obstruction is there, you will refer to surgery. If it is not there, then you will do labs. In labs, CBC, LFT for whether it is a liver abnormality, analyze for whether it is pancreatic abnormalities, then blood cultures, and we will do ultrasound and X-ray. Now start empiric therapy. What is the empiric therapy in fever with abdominal signs? So then there is enteric fever if you are considering, that is injection ceftriaxone or azithromycin. Abdominal sepsis, you should consider piptaz and metronidazole. Anaerobic cover should be there. Okay. Amoebic cover, metronidazole. Liver abscess or dysentery. Malarial cover, injection artesunate. Splenomegaly will be there in the patient. Now de-escalation after 3 days when you get the specific diagnosis. If it is surgical emergency, then post-surgical care should be given. Enteric fever confirmed, then de-escalate only to oral cefixime. Specific diagnosis like UTI and pancreatitis, treat as per guidelines, and symptomatic relief if there is no specific infection. Okay, that's about fever with abdominal signs. Same thing, this is from API textbook of medicine. So intra-abdominal infections, complaint should be abdominal pain. It can be local or diffuse. Fever, diarrhea, nausea, vomiting, or loss of appetite. So you divide this into diffuse abdominal pain and localized abdominal pain. Diffuse abdominal pain, the causes are primary peritonitis or secondary peritonitis. It can be referred pain from vertebral osteomyelitis, okay, discitis, okay, herpes zoster, okay, meaning it can, abdominal pain can be referred from the spine. So we should have spine in mind when you are dealing with abdominal pain. Okay, it can be colitis or it can be a non-infectious cause. Localized abdominal pain can be due to hepatitis, liver abscess or splenic abscess, pancreatitis, pyelonephritis, or renal abscess, diverticulitis, cholecystitis and cholangitis, appendicitis, colitis, pelvic inflammatory disease, endometritis, abdominal tuberculosis. How you will differentiate? So localized abdominal pain and diffuse abdominal pain. So according to this flowchart, you should exclude the surgical emergency. Okay, then if surgical emergency is not there, then consider as low risk, and then you will proceed with investigation and radiology investigation. But according to this API algorithm, you should go by localized pain or diffuse pain. Okay, history and clinical examination, local or diffuse abdominal pain or tenderness, patient position, rapid and shallow breathing, referred pain, anorexia, nausea, vomiting, distended abdomen, constipation or bloody diarrhea, tachycardia, fever or abdominal tenderness. Blood test, what you order? CBC, amylase for pancreatitis, lipase, same, KFT, LFT for liver pathology, and procalcitonin for rolling out bacterial infection. Self-fluid analysis, protein, sugar, if there is ascites, okay, total count and differential count, and ADA for urine tuberculosis. Microbiology, blood cultures, fluid cultures, peritoneal lavage, CB0 for tuberculosis, AFB, stool culture, Clostridium difficile, toxin A and toxin B. Okay, urine routine examination. Okay, histopathology examination include omentum biopsy, endoscopic ultrasonography, guided lymph node biopsy. Radiology includes CT scan abdomen or X-ray abdomen. These two are very important investigation in fever with abdomen. X-ray, ultrasonography, X-ray abdomen, or CT scan abdomen and X-ray. These are the must do radiological investigation in patients fever with abdominal signs. Now coming to the fever with genitourinary symptoms. So in fever with genitourinary symptoms, so it can be complicated UTI or it can be pelvic sepsis. So patient presentation will be fever with dysuria or frequency or flank pain or suprapubic pain. Okay, the costovertebral angle tenderness, costovertebral meaning that renal angle tenderness, vaginal or urethral discharge, immediate stabilization by circulation, pain management, lab, urine analysis, CBC, CRP, blood culture, and ultrasound, KUB or CT abdomen pelvis. Now, you will rule out the high risk patient. How you will rule out whether it is a complicated genitourinary or it is uncomplicated. So whether it is complicated or upper tract disease, you should rule out. How? High fever, presence of rigors, presence of flank pain, patient is vomiting, whether or if the patient is male patient or pregnant lady, male patient or pregnant lady. So these all features. What are these features? High fever, rigors, flank pain, vomiting, male, pregnant. These point toward high risk, and you should admit the patient and give IV therapy with imaging. Rule out obstruction and abscess. Start parenteral antibiotics. Okay, and if these things are not there, then it should be uncomplicated cystitis. Give oral antibiotic therapy like niftaz and phosphomycin. Follow up with culture result. Okay, so what is this empiric syndromic IV therapy for complicated cases, which should be started within 1 hour? So that is gram negative cover like E. coli, Klebsiella. You should give injection ceftriaxone 1 to 2 gram IV or ciprofloxacin in role assistant countries. Okay, you should give enterococcus cover. This is important. Okay, in elderly patients and in patients who have catheter or post procedure patients. What is that enterococcus cover? Ampicillin should be given IV injection, ampicillin. Enterococcal cover for elderly patient or patients who have catheter. Okay, Anaerobic cover or pelvic inflammatory disease cover, you should give injection metronidazole along with doxycycline. De-escalate and give definitive care within 2 to 3 days. So culture positive, narrow down to that thing. No growth or symptomatic, reevaluate for non-bacterial cause, abscess or obstruction on imaging, source control, drainage and stenting, clinical improvement, switch to oral therapy to complete course of 1 to 2 weeks. So you should exclude high risk and low risk. Okay, first you should exclude the high risk, then you should proceed forwards with empirical therapy. Same thing from API textbook of medicine. Complaints will be usually dysuria, frequency, urgency, hematuria, suprapubic pain, flank pain, renal angle tenderness. Fever will be there. Other symptoms and signs of systemic illness like chills or rigors, flank pain, costovertebral angle tenderness, well, pelvic or perineal pain in men. So if these are there, then it is complicated. If these are not there, that is not complicated. Complicated means it can be prostatitis, it can be pulmonary it can be renal abscess. So other things which make it complicated are male patients, pregnant ladies, elderly patients, recurrent UTI, catheterized patients, anatomic abnormality in the urogenital system, or immunocompromised patient, or diabetes mellitus patients. All these things make the patient as complicated. If these are not there, then it can be urethritis or cystitis. In urethritis, you will have discharge, cystitis, okay, burning, micturition, epididymitis. Other factors, if the patient is female, it is low risk. Non-pregnant female, it is low risk. First presented, it is low risk. Okay. Distant examination, C for vitals, severe tenderness, suprapubic tenderness, abdominal tenderness, blood test, CBC, LFT, RFT, blood sugars, HbA1c, and procalcitonin, microbiology, blood cultures, aerobic and anaerobic. Unit examination, more than 10 pustules are there, then that should be a urine meaning urine infection. So send for culture, sterile pyuria, AFB culture should be done. Yeah, this is very important. You are having urine routine more than 10 pustules, and patients has complaints, and in culture you are getting sterile pyuria, then the most common cause is the patient has received antibiotics. That is the first common cause. The second common cause is the cause is non-bacterial. Okay, non-bacterial, and the most common non-bacterial, meaning not typical bacterial, it is tuberculosis. AFB culture should be obtained. Then urine for CB NAT should be done in those patients. Radiology, CT abdomen pelvis, cystography, USG abdomen pelvis, DMSC scan. Okay, that's about fever with genitourinary symptoms. Now coming to the last thing, that is fever with multi-organ dysfunction syndrome. So what is the definition? Fever with dysfunction of at least 2 organ systems. Example, renal failure along with jaundice. Common etiologies include severe sepsis, so viral dengue, and bacteria, it is leptospirosis, Weil's disease, and it can be severe malaria also. Okay, that's like that. You should always viral, bacterial, typical, atypical, tubercular, and parasite. Management, ICU admission should be there. Required intensive monitoring. Sepsis bundle, early antibiotics, fluid resuscitation, vasopressors if shock persists. Specific therapy, leptospirosis, you should give ceftriaxone. Scrub typhus, you should give IV doxycycline or azithromycin. So this is the syndromic management of fever with multi-organ dysfunction syndrome. So at least 2 organ systems should be affected. It can be hypotension, cardiovascular hypotension, CNS, altered mental status, LF meaning liver, jaundice, kidney, oliguria, and lungs, respiratory distress. ICU admission and sepsis bundle should be given. Resuscitation and stabilization with IV fluids. And if the shock persists, vasopressors like norepinephrine should be given. Empiric tropical cocktail therapy should be given. What is that? You should include malaria, IV artesunate, ceftriaxone or meropenem. This will cover leptospirosis and sepsis also. For scrub typhus or rickettsial, you need doxycycline. Urgent diagnostics, blood culture, two one for aerobic, one for anaerobic. Lactate should be known, because if it is more than 2, then suspect shock. Okay, CBC, KFT, LFT, and coagulation profile should be obtained, because these patients may be going into disseminated intravascular coagulation, DIC. Okay, malaria, RDT or smear, scrub, IgM, dengue, oh, this should also be done, and leptospirosis, IgM should be also be done. Okay, organ specific supportive care should be given. For respiratory, it is oxygen or mechanical ventilation. For renal, it is renal replacement therapy. For hepatic or hematologic, it is management of the coagulopathy, correction of coagulopathy, and transfusion if bleeding is there. Okay, CNS, control the seizures and airway protection. If there is edema, you give mannitol and this one, NS. Then reevaluate and de-escalate after 2 to 3 days when you have confirmed the etiology. So that's all about the syndromic management of diseases. So one thing I want to highlight, the important drugs which we use. So for viral, remember the drug oseltamivir for influenza, and one thing. Then second one is your acyclovir. For encephalitis, acyclovir. For bacterial, you can divide it into bacterial. So typical bacteria, ceftriaxone or ceftriaxone or meropenem you can give. Okay, meropenem. For atypical, doxycycline should be given. Okay, and for tubercular, ATT should be given. Parasitic, that is nothing but malaria. So IV artesunate should be given, or chloroquine if it is stable. Chloroquine. One more thing in bacteria is anaerobic bacteria. You should have metronidazole for particularly in fever with abdominal patients, fever with abdominal features. Okay, and in urinary tract you should have enterococcus cover, particularly in elderly and catheter patients. What is enterococcus? You should give IV ampicillin. Okay, so that's all about the syndromic management of fever. Thank you.